Beta-adrenergic blockers. Beta-adrenergic antagonists block the beta receptors mediated effects of sympathetic stimulation and adrenergic drugs. Classification: beta blockers. First generation, second generation, and third generation beta blockers. First generation beta blockers, also known as non-selective beta adrenergic blockers. Second generation known as beta 1 selective adrenergic blockers, and third generation known as beta blockers with additional vasodilatory effects, which can be further classified as non-selective and beta 1 selective. First generation drugs include timolol, nadolol, pindolol. Second generations include atenolol, acebutolol, and esmolol, also metoprolol. Third generation, which is divided into non-selective, includes carvedilol and labetalol, and beta 1 selective include betoxolol, celiprolol, and nebivolol. Mechanism of action: beta blockers competitively block the beta receptors mediated action of catecholamines and other adrenergic agonists. Pharmacological properties of beta blockers: cardiovascular system. Heart: beta blocker depress all the cardiac properties. It decreases the heart rate, that is negative chronotropic effect. It decreases the force of myocardial contraction, that's negative ionotropic effect. It decreases the cardiac output. It also depresses the SA node and AV nodal activity. It increases the refractory period of the AV node. It decreases the conduction in the atria and the AV node, that is negative dromotropic effect. Blood vessels. Blockage of the beta 2 receptor of the blood vessel initially may cause a rise in the peripheral vascular resistance due to unopposed alpha 1 action. However, continued administration of these drugs will lead to fall in the peripheral resistance in the patient with hypertension due to chronic reduction in the cardiac output. Both systolic and diastolic blood pressure gets reduced. They also reduce the release of renin from juxtaglomerular apparatus due to the blockage of the beta 1 receptor and decrease the central sympathetic outflow. Respiratory system. Blockage of the beta 2 receptor in the bronchial smooth muscles can produce severe bronchospasm in the patient with the COPD and the asthma. Therefore, beta blockers should be avoided in patients with asthma and COPD. Selective beta 1 blockers such as atenolol, metoprolol, etc. are less likely to cause bronchospasm. Skeletal muscles. On chronic uses, beta blockers may cause skeletal muscle weakness and tiredness due to blockade of the beta 2 receptor of skeletal muscle and blood vessels supplying them. It also reduces the stress-induced tremors. Metabolic effects. Beta blockers inhibit the glycogenolysis and delays the recovery from hypoglycemia. They also mask the warning signs and symptoms of hypoglycemia, and therefore beta blockers should be used cautiously in the diabetic patients and hypoglycemic, as it is a hypoglycemic agent. Chronic use of non-selective beta blockers decreases the HDL, cholesterol, and LDL cholesterol ratio, which may be increase the risk of coronary artery disease. Eyes. Beta blocker on topical administration decreases IOP, that is the intraocular pressure, by reducing the secretion of aqueous humor. Pharmacokinetics. Propranolol is highly lipid soluble and is well absorbed from GI tract. However, the bioavailability of the propranolol is low because of its extensive first pass metabolism. It is highly bound to the plasma protein and has a large volume of distribution, freely crosses the BBB and metabolites and excretes in the urine. Adverse effects of beta blockers. They are mainly an extension of the pharmacological action on CVS, bradycardia, heart block, and may precipitate congestive heart failure in patients with low cardiac reserve. Blockage of the vascular beta 2 receptor can cause unopposed alpha 1 action that reduces further blood supply and may worsen the peripheral vascular disease. Beta blockers can exacerbate the variant angina due to unopposed alpha 1 action and hence contraindicated in this condition. Respiratory system. Blockage of the beta 2 receptor in the bronchial smooth muscle can cause severe bronchospasm in the patient with asthma and COPD. Hence, beta blockers are contraindicated in the above conditions. CNS. Sleep disturbance, hallucinations, fatigue, and mental depressions. These are the symptoms seen due to beta blockers. Metabolic recovery from hypoglycemia induced by anti-diabetic drugs is delayed by the beta blockers. Beta blockers may mask the warning signs and symptoms of hypoglycemia, muscular weakness, and tiredness. These are due to reduced blood flow to the skeletal muscle. Withdrawal symptoms. Abrupt withdrawal of the beta blockers after chronic use is dangerous because of angina or frank myocardial infarction, and even sudden death can occur. This is due to upregulation or supersensitivity of beta blockers in the response to prolonged blockade. Drug interactions. Propranolol and verapamil. They produce additive cardiac depressant effect and may cause CCF, bradyarrhythmias, heart block, and even cardiac arrest. Propranolol and lignocaine. Propranolol reduces the clearance of the lignocaine by decreasing the hepatic blood flow. Cholestyramine and cholestyramine into beta blockers. Cholestyramine and cholestyramine are bile acid binding resins. They bind to the beta blockers in the gut and interfere with the absorption of the beta blockers. Insulins into beta blocker. Non-selective beta blocker inhibit the glycogenolysis and delays the recovery from hypoglycemia. Propranolol and non-steroidal anti-inflammatory drugs. The NSAIDs by inhibition of prostaglandin synthesis promote the sodium and water retention on the chronic use, thus they decrease the antihypertensive effects of beta blocker. Propranolol and chlorpromazine. Propranolol interfere with the first pass metabolism of chlorpromazine and increases its bioavailability. Therapeutic use of beta blockers. Hypertension. Beta blockers are useful for all grades of hypertension. These drugs are preferred especially in patients with angina, myocardial infarction, and cardiac arrhythmias. The advantages of beta blockers are sodium and water retention is rare, they are cheaper, have a long duration of action, and they are well tolerated inside the body. Angina prophylaxis and myocardial infarction. Beta blockers reduce myocardial oxygen demand by decreasing the heart rate, myocardial contractility, and arterial pressure. They improve the exercise tolerance and reduce the frequency of anginal episodes. Use of beta blockers early in acute phase of MI may limit infarct size. Long-term use of beta blocker may reduce the mortality and reinfarction. Cardiac arrhythmias. Beta blockers are mainly used in the arterial arrhythmias such as atrial fibrillation and atrial flutter, but rarely for ventricular arrhythmias. Congestive cardiac failure. Chronic use of beta blockers such as carvedilol, metoprolol, and bisoprolol had shown to reduce mortality rate in chronic heart failure. Pheochromocytoma. Beta blockers are used to control the cardiac manifestation of pheochromocytoma but should not be given alone. Glaucoma. Beta blocker decrease the IOP by reducing the production of the aqueous humor. They are useful in treatment of glaucoma. Timolol, ketilol, lebutalol, butoxolol, etc. are topically in glaucoma. They are given. Timolol is the most frequently used beta blocker in glaucoma. Butoxolol is a selective beta-1 blocker and hence systemic adverse effects are rare. Prophylaxis of migraine. Propranolol and metoprolol are effective in reducing the frequency of migraine headache. This mechanism is not known. Hyperthyroidism. Signs and symptoms of hyperthyroidism such as tachycardia, palpitation, tremor, anxiety are reduced due to the blockage of the beta receptor. Propranolol inhibit the peripheral conversion of T4 to T3 and also used in the thyroid storm. Essential tremors. Oral propranolol may give some benefits to the patient with essential tremor. Acute anxiety state. Beta blockers are used in controlling the symptoms of acute anxiety such as palpitation, tachycardia, tremors, and sweating. Alcohol withdrawal. Propranolol may produce some benefits in treatment of alcohol withdrawal. Hypertrophic obstruction and cardiac myopathy. Propranolol decreases outflow resistance. Dissecting aortic aneurysm. Beta blockers are useful in management of the dissecting aortic aneurysm. They decrease the cardiac contractility and rate of development of pressure during the systole. Selective beta-1 adrenergic blockers. Esmolol. It is having a T half of about 10 minutes. It's administered intravenously. It has no membrane stabilizing effect, no intrinsic systemic sympathomimetic activity, and it's also selective beta 1 blocker, has a short duration of action. Esmolol is used for rapid control of ventricular rate in the supraventricular arrhythmias, and it is also useful in hypertensive emergencies. Other beta 1 adrenergic blockers like atenolol. Next, we come to beta blockers with additional vasodilatory action. They include labetalol, carvedilol, celiprolol, and nebivolol. All these are the third generation beta blockers with additional vasodilatory action, especially talking about the nebivolol. So it has nitrogen oxide mediated vasodilatory action, and it's having no membrane stabilizing activity, no intrinsic sympathomimetic activity, no unfavorable effects on lipid profile, and it is also used for control of hypertension and congestive cardiac failure.